Hello, class. So in today's lecture, we will be discussing the upper limb, the shoulder complex, and a structure called the axilla. We'll first start the discussion covering the upper limb, and I want you to be able to feel comfortable stopping this presentation at any point and going backwards and reflecting or reviewing some information that you feel weak on or that you need further clarification on. So when we speak of the upper limb, anatomically, what are we talking about? The structure that you see in front of you is not anatomically referred to as the arm, it is anatomically referred to as the upper limb. The upper limb is subdivided into an arm, a forearm, and a hand. The general bones that form the upper limb include the humerus bone, most proximal to the thoracic cage. Moving inferiorly from the humerus, we will find the ulna, located medially, and the radius, located laterally. The ulna and the radius are the two bones of the forearm. Moving in the direction of the hand, we run into another 8 bones called carpals here in the wrist region. We have metacarpals, 5 of them that form the bones of the palm. And then we have 14 phalanges on each at each digit. Another significant group of bones that is associated with the upper limb are bones of the shoulder girdle. Those include the clavicle here anteriorly, and posteriorly we have the scapula. So these different bones articulate at areas referred to as joints. Here, most proximal, we have the shoulder complex. I like to refer to the shoulder not as a joint, but as a complex of joints, muscles, ligaments, and tendons that all are involved in, yes, mobility, but also stabilizing the complex, which is the shoulder. Between the humerus and, or I should say, between the arm and the forearm, we have the elbow joint. Between the forearm and the hand, we have the wrist. Here, between the carpals and the metacarpals, we have the metacarpophalangeal joints, just at the base of the digits or at the base of the phalanges. And then the joints between each segment of the phalanxes or the phalanges, we have the interphalangeal joints. It's important to note that digits 2, 3, 4, and 5 have 2 interphalangeal joints, whereas the first digit has only a single interphalangeal joint. The subclavian artery on the right and left side and its subsequent branches supply the upper limb with oxygenated blood. The right subclavian artery arises from the brachiocephalic trunk, and the left subclavian artery arises from the aortic arch. The subclavian artery travels distally and becomes the axillary artery as it crosses over the lateral border of the first rib, which is visualized here. The axillary artery will then continue distally and become the brachial artery at the point of the inferior border of the teres major muscle, which you can visualize here. The brachial artery, continuing distally here, and also here, will actually move anterior to the humerus, which you can visualize, and upon entering the antecubital fossa, which is the anterior portion of the elbow joint, will bifurcate into an ulnar, right here, and a radial artery, which travel medially and laterally respectively. These arteries will actually continue into the hand, where they anastomose, another word for unite, to form the superficial and deep palmar arches. Throughout the upper limb, smaller vessels and branches from the larger vessels will then supply structures such as muscles, bones, and joints, as well as the skin of the upper limb. Blood is returned from the upper limb to the heart via a superficial and a deep venous system. Laterally, so on this side, the cephalic vein will carry blood from the forearm to the subclavian, eventually to the subclavian vein, and medially, the basilic vein moves superiorly and unites with the deep axillary vein. Upon entering the antecubital fossa, these two veins anastomose here via the median cubital vein. Given that the deep venous system follows its arteries, most of the deep veins have the same name as their accompanying arteries, such as the radial vein, the ulnar vein, brachial veins, an axillary vein, and a subclavian vein, which enters into ultimately the superior vena cava. The upper limb is innervated nervously by the ventral primary rami originating from spinal nerve levels C5 through T1. So C5, C6, C7, C8, and T1 ventral primary rami will begin to form this structure here. These rami will eventually form this structure, which is a network of nerves referred to as the brachial plexus. The brachial plexus extends from the neck, located somewhere around here, down or distal towards the axilla, providing motor and sensory innervation to the upper limb. The brachial plexus consists of the following important regions. It is composed of roots, most proximal, then moving distally, trunks, divisions, cords, and branches. It's important to note that the brachial plexus exits between two key muscles, visualized here, those being the anterior and the middle scalene muscles. Terminal nerves of the brachial plexus supply muscles, but they also supply dermatomes. A dermatome is a region of skin that is innervated by sensory fibers originating from one specific spinal nerve level. Therefore, all sensory neurons leaving that region of skin course to the same segmental spinal nerve level. The following are the primary places to touch a patient in order to test specific dermatomes in the upper limb. At the C5 region, this is located on the lateral side of the elbow. And just for your orientation, this is an anterior view of a right arm or a right upper limb, and this is the posterior view of a right upper limb. C6 sends nerve innervation to the dorsal, or I should say receives nerve innervation from on the dorsal surface of the proximal phalanx, also referred to as the thumb or the first digit. C7 to the dorsal surface of the proximal phalanx and the middle finger. C8 to the dorsal surface of the proximal phalanx of the little finger, and T1 to the medial side of the elbow. These cutaneous nerves are responsible for providing sensory innervation to these specific regions of the skin, sometimes referred to as cutaneous fields. Cutaneous nerves are considered sensory only, but you should also remember that they also distribute sympathetic nerves to the cutaneous organs like sweat glands and blood vessels that supply the skin. So now let's talk a little bit more about the shoulder. So we mentioned the shoulder being a complex of different components. So this shoulder complex is actually a combination of 4 different joints that provide a wide range of motion between the shoulder girdle and the upper limb. The shoulder complex is stabilized by bony joints within the shoulder girdle and by a specific group of muscles as well. So before discussing joints and muscles that are at play in the shoulder, I think it's very important to discuss the osteological features that comprise attachment points for the ligaments and tendons that supply and act within the shoulder. So first, the clavicle, or the collarbone. This guy is the only bony attachment between the upper limb and the axial skeleton, where it meets here medially. It is superficial along its entire length and shaped like an S. The clavicle provides an attachment for muscles that connect to the clavicle to the trunk and to the upper limb. The following landmarks are found here on the clavicle. Notably, the acromial end, which is lateral. The acromial end articulates with the acromion process of the scapula and forms the acromioclavicular joint. Over here, medially, the sternal end articulates with the manubrium of the sternum and forms the sternoclavicular joint, and the conoid tubercle located on the inferior surface of the lateral clavicle. The conoid tubercle serves as an attachment point for the corticoclavicular ligament. The scapula, or the shoulder blade, is a large, flat, triangular-shaped bone with 2 angles, a superior angle up here and an inferior angle down here. It has 3 borders, a superior, a lateral, and a medial border. I'm sorry, I got that backwards. Superior, medial, and lateral. It also has 3 different processes and acromion superiorly. It has a spine, which you can visualize here from the posterior view, the spine of the scapula. If we follow the spine laterally, we eventually run into the 3rd process, which is called the coracoid. So the spine of the scapula is continuous with the acromion, which is superior and then inferior to the acromion. We can then visualize the coracoid process here, which is inferior and anterior to the acromion. The following landmarks that are found on the scapula also include the subscapular fossa here, which is located anteriorly and characterized by this shallow concave fossa. Because the subscapular fossa glides upon the ribs, so you can imagine the thoracic cage right here anterior to the scapula, which the scapula glides across. It is also known as the costal surface here anteriorly. This costal surface serves as an attachment point for the subscapularis muscle in the subscapular fossa. We did mention the acromion, which is this large projection of the anterolateral surface of the spine. The acromion will then arch over the glenohumeral joint and articulate with the clavicle. The spine here posteriorly is very prominent on patients and is palpable with the hand. The spine subdivides the posterior surface of the scapula into a small supraspinous fossa and a larger infraspinous fossa. The spine serves as an attachment for the trapezius muscle and for the deltoid muscles. The supraspinous fossa is located on the posterior surface of the scapula and superior to the spine of the scapula. The supraspinous fossa serves as an attachment point for the supraspinous muscle. The suprascapular notch, again visualized here, is a small notch medial to the root of the coracoid, right here. The supraspinous fossa serves as an attachment point for the supraspinatus muscle. The infraspinous fossa, which is located here, is located on the posterior surface of the scapula and inferior to the spine. The infraspinous fossa serves as an attachment point for the infraspinatus muscle. The glenoid cavity, which is visualized here and here, is a shallow cavity that articulates with the head of the humerus to form the glenohumeral joint. The supraglenoid tubercle, so this prominence up here, is located superior to the glenoid cavity and serves as the attachment point for the long head of the biceps brachii. The infraglenoid tubercle here is located inferior to the glenoid cavity and serves as the attachment point for the long head of the triceps brachii muscle. Lastly, the coracoid process is a prominent and palpable hook-like structure inferior to the clavicle. The coracoid process serves as an attachment point for the pectoralis minor, the coracobrachialis muscle, and the short head of the biceps brachii muscles. The humerus is the longest bone of the upper limb and is characterized by many distinct features that allow the upper extremity to move through a significant range of motion. The following landmarks are found on the proximal humerus. The head, which is a ball-shaped structure articulating with the glenoid cavity of the scapula. The anatomical neck here, which is formed by a narrow constriction immediately distal to the head of the humerus, the anatomical neck. The surgical neck lies distal to the anatomical neck and the tubercles of the humerus. The axillary nerve and the posterior humeral circumflex artery course into the posterior compartment of the arm deep to the surgical neck. The greater tubercle, visualized here, is a lateral enlargement on the proximal posterolateral humerus. The greater tubercle is an attachment site for the supraspinatus, infraspinatus, and teres minor muscles. The lesser tubercle, which is visualized here, is a smaller enlargement on the proximal anterior humerus and is the attachment site for the subscapularis muscle. The intertubercular groove, or the bicipital groove, visualized here, is a deep sulcus between the greater and lesser tubercles, where the long head of the biceps brachii tendon courses through en route to the supraglenoid tubercle of the scapula. And lastly, the radial groove is a distinct groove on the posterior surface of the humerus where the radial nerve and the deep brachial artery course. The shoulder joint complex is capable of a wide range of motions. It is capable of such motions including flexion anteriorly and extension posteriorly. It's also capable of abduction, so movement away from the body, and adduction, movements toward the body in the lateral plane. Circumduction, which is a combination of shoulder movements that allow the hand to trace a circle and the arm to trace a cone. And lastly, medial and lateral rotation of the humerus. Though the complex shoulder joints benefit from these large ranges of motion, it actually comes at a price of being susceptible to dislocation in the 90-degree abduction point out here, and 90-degree external rotation. So when the humerus is rotated 90 degrees externally due to a lack of ligamentous support and dynamic stabilization. As a counterbalance to great mobility, there are 4 joints that provide stability and measured mobility to the shoulder complex. Those joints include the sternoclavicular, coracoclavicular, acromioclavicular, and glenohumeral joints. These subsequent joints are established by their respective bone-to-bone ligaments. For example, the sternoclavicular ligament is a broad ligament that attaches to the anterior superior part of the clavicle's sternal end above here and passes down inferomedially to the upper anterior aspect of the manubrium. The ligament then expands into the first costal cartilage. The coracoclavicular ligament joins the coracoid process of the scapula to the inferior surface of the lateral end of the clavicle and consists of 2 parts, trapezoid and conoid. There may also be fat or a bursa between these 2 parts. The coracoacromial ligament is a triangular band of 2 fascicles. The coracoacromial ligament originates from the lateral aspect of the coracoid process and attaches to the anterior, medial, and inferior surfaces of the acromion. The coracoacromial arch is actually formed by the coracoid process, the acromion, the acromioclavicular joint, and the clavicle, and the coracoacromial ligament, which is visualized here. The coracoacromial arch stabilizes the humeral head and prevents superior ascent. The subacromial bursa is located between the acromion, the coracoacromial ligament, and the rotator cuff, which we will discuss here shortly. And last but certainly not least, the glenohumeral joint is a movable synovial ball and socket joint between the shallow glenoid cavity, also called the glenoid fossa of the scapula and the hemispherical head of the humerus. The articular surface of the glenoid fossa, as well as the head of the humerus, is lined with hyaline cartilage. Over the humeral head, this hyaline cartilage is thicker here towards the middle and thinner as we move towards the periphery. The shallow curve of the glenoid fossa makes the socket component of the glenohumeral joint. However, it's not actually a very good socket at all. In addition, the surface area of the humeral head is approximately 4 times larger than that of the glenoid cavity. So you can imagine that results in a relatively small contact area between the two at any given time. This is beneficial for us in terms of mobility of the glenohumeral joint, but it also means that stability is compromised. There are, however, some extra structures that support the shoulder joint and help to give it some extra stability. In fact, the shoulder relies more on the surrounding muscles and ligaments for its stability than it does on its bony elements. The first of these structures is the glenoid labrum, which is a fibrocartilaginous ring attaching around the outer margin of the glenoid fossa. The glenoid labrum helps to deepen the fossa and provide the joint socket with more of a functional shape. Surrounding the glenohumeral joint is the joint capsule. Like all synovial joints, the joint is made from an outer fibrous layer and of an inner synovial membrane. The inner synovial membrane of the glenoid capsule secretes synovial fluid, which fills and lubricates the joint capsule. The fibrous part, which you can see here in green, actually engulfs the whole humeral head and extends to the anatomical neck of the humerus. The fibrous part of the glenoid capsule is formed by and continuous with 4 different ligaments that stabilize the glenohumeral joint. Those ligaments being the coracohumeral ligament, the superior, middle, and inferior glenohumeral ligaments as well. In addition to bony and ligamentous structures, the shoulder joint complex is also stabilized by a number of muscles, starting with the rotator cuff muscles. The muscles are considered a cuff. The muscles of the rotator cuff, I should say, are considered a cuff because the inserting tendons of these muscles blend with the glenohumeral joint capsule to help stabilize the humeral head in every position and keep it centered during movements. The muscles consist of the supraspinatus, infraspinatus, teres minor, and subscapularis. You can see that the first letter of each muscle forms an acronym which identifies them as the sits muscles. All muscles of the rotator cuff are innervated by ventral primary rami of spinal nerves C4, C5, and C6, except the subscapularis muscle, which is innervated by C5, C6, C7 ventral primary rami. The supraspinatus muscle, visualized here in green, arises from the supraspinous fossa of the scapula, and its tendon inserts on the upper facet of the greater tuberosity of the humerus in order to initiate humeral abduction. So when this muscle contracts, it initiates the movement of the humerus away from the body. The infraspinatus muscle originates from the infraspinous fossa of the scapula, which is visualized posteriorly. The infraspinatus muscle inserts distally on the middle facet of the greater tuberosity of the humerus. When this muscle contracts, it acts to laterally rotate the humerus. So rotating the humerus and the hand outwardly in lateral rotation. The teres minor muscle arises from the upper two-thirds of the lateral border of the scapula and the lowermost of the three facets of the greater tuberosity of the humerus. The teres minor is an adductor, meaning it pulls the humerus towards the body, and the teres minor also laterally rotates the humerus and opposes superior subluxation of the humerus. Subluxation is partial dislocation, so you can see its attachment points will prevent the humerus from subluxing superiorly and upward. The subscapularis muscle arises from the subscapular fossa of the scapula, which is visualized from the anterior view of the scapula. The subscapularis inserts on the lesser tuberosity of the humerus, and when it contracts, the subscapularis both adducts, so it pulls the humerus towards the body, towards the midline, and it also medially rotates the humerus. So medial rotation, meaning the hand, if it's open and in the prone position, will rotate towards the midline. So thumb outward in the prone position or the anatomical position, rotating towards the navel, towards the midline, is medial rotation of the humerus. Outside of the rotator cuff muscles that directly add stability to the glenoid capsule and the glenoid fossa, there are 4 other muscles that assist in stabilizing the shoulder complex. The deltoid muscle is a thick, powerful muscle which covers the shoulder joint and the upper humerus. It has an anterior, visualized here, an anterior, a middle here, and a posterior portion that flex anteriorly, powerfully abduct laterally, and extend the humerus posteriorly, respectively. The deltoid muscle is innervated by C5 and C6 ventral primary rami. Proximally, the biceps brachii has 2 different heads. It has a long head, visualized here, and it has a short head here. The 2 heads unite in the lower portion of the muscle and insert here into the forearm. The tendon of the long head of the biceps arises within the shoulder joint capsule up here and moves inferiorly to insert into the radial tuberosity of the forearm's radius. The biceps brachii is a powerful supinator and flexor of the forearm, as well as an extensor of the humerus. It is also innervated by ventral primary rami, C5 and C6. The teres major muscle, visualized here in green, arises from a raised oval area at the dorsal aspect of the inferior angle here and inserts into the adjacent lateral border. And it also originates here from the adjacent lateral border of the scapula. The teres major will move laterally and insert as a broad flat ligament on the medial lip of the intertubercular groove. The teres major is separated from the tendon of the latissimus dorsi by a bursa, which you can see here, as well as here, and is innervated differently from the previous two. This one is innervated by ventral primary rami C6 and C7. Lastly, the triceps muscle is a large muscle occupying the extensor compartment of the arm. The triceps brachii arises from three different heads, a medial, a lateral, and a long head from which it gets its name. The long head of the triceps brachii is the only head that crosses the shoulder joint, and which you can see here, highlighted in green. It arises from the tendon attached to the infraglenoid tubercle of the scapula and inserts on the olecranon process of the ulna to both stabilize the shoulder complex and to weakly extend the humerus. The long head of the triceps brachii is also innervated by ventral primary rami C6 and C7. Now let's move on to discussion about the axilla. So the axilla, colloquially referred to as the armpit, is an anatomical region under the shoulder joint where the arm of the upper limb connects with the shoulder. However, rather than being a two-dimensional area simply over the skin of the underarm as what's shown here, it's better to consider the axilla as a three-dimensional space that contains a variety of neurovascular structures. The axilla should truly be thought of as a pyramidal shape that is bounded superiorly by the root of the neck, inferiorly by the axillary fascia, subcutaneous tissue, aka fat, and skin. Anteriorly, the axilla is bounded by the pectoralis major muscle. Posteriorly, it is bounded by three different muscles, the teres major, the subscapularis, and the latissimus dorsi. Medially, here in purple, the axilla is bounded by the serratus anterior muscles, which lie lateral to the thoracic cage. And laterally, the axilla is bounded by the intertubercular sulcus of the humerus. So what are the contents of the axilla? The space which the axilla occupies contains the short head of the biceps brachii. It contains the coracobrachialis muscle. The axilla contains the axillary artery and vein, as well as the three cords of the brachial plexus, namely the lateral, the posterior, and the medial cord. A final key group of structures within the axilla include axillary lymph nodes, which receive lymphatic drainage from the upper limb, posterior, and anterior thoracic walls. The pectoral nodes, visualized here, receive lymphatic drainage from the subareolar lymphatic plexus and the interpectoral nodes within the breast, which empty into the pectoral nodes of the axilla. Nodes at the base of the axilla, visualized here, the pectoral, subscapular, and humeral nodes all drain into the central and apical nodes. Lymphatics exit the axilla to join the supraclavicular nodes, visualized here, over the clavicle, which then enter the subclavian lymphatic trunk and then the right or left venous angle before they finally empty into the subclavian veins for venous return to the heart. With that, this completes our discussion of the general upper limb, the shoulder, and the axilla.